Hello friends, greetings from RFA Tutors. I'm here to discuss the Green Top Guideline of the day, the management of thalassemia in pregnancy. The Green Top Guideline 66 published in March 2014. The major homozygous beta thalassemia results from the inheritance of defective beta globin gene from each parent. This results in a severe transfusion-dependent anemia, that is, more than 7 transfusions per year. The minor is a heterozygous state. The beta thalassemia trait causes mild to moderate microcytic anemia with no significant detrimental effect on the overall health. Do not require transfusion. The intermediate is defined as a group of patients with beta thalassemia whose disease severity varies, usually diagnosed between the ages of 2 and 6 years, 7 or less transfusions per year. It's an important single-best answer. There are risks to the mother and the baby: the maternal cardiomyopathy due to iron overload, diabetes, hypothyroidism, and hypoparathyroidism, and in the fetus, fetal growth restriction. It has to be a multidisciplinary team, the obstetrician and the hematologist friends, and review the blood transfusion requirements, chelation therapy, desferoxamine, only chelation agent for second and third trimester, all chelation agents teratogenic in first trimester, and the body iron burden needs to be taken into account as well. Screen for end organ damage. Fertility may be reduced in transfusion-dependent individuals due to organ overload causing anti-pituitary damage, so may require gonadotropin-releasing hormone as ovulation induction. The pancreas, patient with known diabetes, serum fructosamine concentration less than 300 nanomole per liter for at least 3 months prior to conception, equivalent to HbA1c 43 millimole per mole, HbA1c not reliable marker in thalassemia, as diluted by transfused blood, results in underestimation. The patient should be euthyroid. Hypothyroidism is frequent with thalassemia. If found hypothyroid, treatment should be started. Heart echocardiogram ECG, cardiac MRI, a more than 20 millisecond minimal iron in the heart, if less than 10 millisecond, increased risk of cardiac failure. The bone density scan to detect the pre-existing osteoporosis, vitamin D concentration should be optimized. The liver, FerriScan liver T2, aim less than 7 milligram per gram density weight, more than 15 milligram per gram, risk of myocardial iron load increases, so preconception iron chelation recommended. Ultrasound liver, gallbladder, and spleen. The cholelithiasis is common in thalassemia, risk of cholecystitis in pregnancy, the liver cirrhosis in HCV positive. The red cell antibody alloimmunity 16.5%. The medications defersirox, deferpirone, bisphosphonates discontinue 3 months before conception, a very important exam point. And remember the genetic screening. If the partner screening is positive, screen the egg and sperm donors for hemoglobinopathies as well. The hepatitis B in all vaccination needs to be given in patients with splenectomy, H. influenza type B, meningococcal C, and pneumococcal vaccine as well. Penicillin prophylaxis in patients with splenectomy. 5 milligram folic acid is the vitamin which they need to take. This is the inheritance pattern, and one extended match question definitely comes from this. It has to be a multidisciplinary team, friends, with obstetrician, hematologist, cardiologist, diabetologist, midwife, monthly review until 28 weeks, fortnightly thereafter. Early scan, 7 to 9 weeks, first trimester, 11 to 14 weeks, anomaly scan, 18 to 20 plus 6, fetal biometry scan every 4 weeks from 24 weeks. Splenectomy plus platelet less than 600 into 10 raised to power 9. Low dose aspirin needs to be given 75 milligram per day. And the splenectomy with platelets more than 600 into 10 raised to power 9, aspirin plus low molecular weight heparin would be there. So the booking appointment, Appendix 1, the schedule of the antenatal appointments, the Appendix 2, continuation of Appendix 2, all these are very important exam questions. They pick up a gestation and they ask you a question from there. MDT, timing of delivery as per national guidelines, not a contraindication for vaginal delivery. We back blood cross match if atypical antibodies present, otherwise group in safe. In thalassemia major, IV desferoxamine 2 gram over 24 hours during labor. Continuous electronic fetal monitoring. If hemoglobin less than 10 gram per deciliter, cross-match 2 units at admission. High risk for VTE, breastfeeding safe and encouraged. Restart desferoxamine as soon as 24-hour infusion of desferoxamine finishes. All contraceptive methods are safe. May that be combined oral contraceptive pills, progesterone-only pills, Mirena, Implanon, and the intrauterine copper device. Some important exam points from the Green Top guideline are the types of the thalassemia in terms of the transfusion required, the antenatal care, and the low molecular weight heparin indications as well. Best of luck from the entire team of RFA tutors. I thank you all for being with us. Until we meet again, take very good care of yourself. Bye-bye.